for your introduction. The idea is to talk about the novel approaches to tackling calcified lesions and CTOs in BTK. So let's start, as always, talking about the crossing strategies. So we have multiple options, antegrade and retrograde, in the luminal and subintimal, and from the retrograde axis as well, transcollateral or pedal-plantar loop. In calcified arteries, subintimal is the second option for sure, and in most of the cases, we need a mix of strategies. But the most important point is that if we fail to cross, we fail to treat the patient. So we know that in BTK-BTA revascularization, up to 20% of patients or treatment fails or obtain poor result, more related to calcifications, high grade of MAC. The combination of bad and sad MAC is one of the biggest problems we face every day, and it creates difficulties to cross, to prepare, and to treat the arteries. We will face also high rate of restenosis at 6 and 12 months, high rates of repeated procedures, TLR, and no healing ulcers, and it will for sure increment the cost for the medical healthcare systems. I will start with a case. This is an 83-year-old male with diabetes, a smoker, dyslipidemia, hypertension, coronary arterial disease, previous stroke, left foot CLI, Rutherford 5 class, TCPR2 is very low, and the Wi-Fi class is 131 with a ulcer in the third toe. This is the case. I did an antegrade access in the common femoral, and the ultrasound, you can see the needle, the guide wire, wiring super selectively the SFA. We deploy a 6-French sheath, and we start after this with the angiography. CO2 angio show us a patent femoral artery. You can see which good images we can obtain with CO2, some stenosis in the P1 segment, and no vessels below the knee. So very poor below the knee vessels and very poor outflow runoff. Just one peroneal artery feeding finally a distal dorsalis pedis. So for sure it's a good case, complex one, calcified, but with many options for us to treat the patient. We start with an 4-French catheter and 018 guide wire. We try to stay in the lumen, but we failed, so we left the wire go subintimally. We did some segment of anterior tibial with the loop-shaped tip. Finally, the wire was navigating at the median part of the anterior tibial, but we failed to reach the distal lumen. So we did a retrograde access in the dorsalis pedis. It allowed us to connect the antegrade with the retrograde segment, and finally the through and through. It allowed us to push down the devices and to pass a second 014 guide wire in the dorsalis pedis. And the complexity of the case starts just there, because it was so difficult to advance with the balloons as well with the guide wire in this small calcified dorsalis pedis. So predilatation of anterior tibial, predilatation of femoral artery to try to reduce the frictions, and finally you can pretty well see how small is this dorsalis pedis and how calcified. Finally, with the support catheter, we were able to pass the 014 guide wire, but again, we start to have some problems to push down in the foot the 2 millimeters very short balloon. It was 240. We predilate multiple times till we arrive in a place in which the balloon was not able to advance, the place in which the artery was so small. So after changing multiple times the balloon, we decide to go for the Pierce technique. It means to cracking the calcium by external puncture. This is an 19-gauge needle, so aggressive. And finally, the balloon was able to transit, to pass in this calcified occlusion and allow us to prepare the vessel for the final treatment. So this is one of the tools we have today to fight against calcium. For sure, all the elements we have today to treat calcified arteries means that before we must to cross the lesion and to pass the guide wire. So we need for sure the support of the technology with the new generation of guide wires that in most of the cases allow us to cross, as well as the support from the industries to treat these arteries, or a creativity to be able to open properly those arteries. Finally, we did a 2 millimeters and 2.5 millimeters balloon angioplasty of this dorsalis pedis, 5 millimeters angioplasty of the popliteal artery and the distal SFA, and we will check for the result we were able to obtain. Some no flow limiting dissections and direct blood flow from the SFA to the POP to the anterior tibial. You can clearly see which segment were subintimal but still functioning, an excellent result in dorsalis pedis, obtaining and giving a direct flow for the foot even if it was not the best result we can obtain. But we have some other technologies. This is a trial that Bruno is participating to about the shockwave in below the knee and how to treating to understand how many lumen we can gain with the technologies. This is the concept of the lumen gain, the net gain. We check the vessel before to use shockwave, after shockwave, and after 15 minutes before to finish the procedure. This is a case of those, 79 years old male, left CLI, diabetes, dyslipidemia, hypertension, previous target limb revascularization by PTA, Rutherford 5, TCPO2 very low again, Wi-Fi class 232 with gangrene in the first toe. Again, we start with an antegrade access in the common femoral, CO2 angio that show a good femoral artery, very low flow in the femoral artery with CO2, but acceptable to have the diagnosis and to realize where the lesions were. So patent femoral artery. The same in the popliteal artery, so again, a pure below the knee and below the ankle case. Again, very slow flow. It's relatively frequent with CO2 because it's a gas and can create some spasm distally. So having a slow flow phenomenon with CO2 angio is quite normal. We can see the ostium of anterior tibial and the TP trunk there. And again, we will focus in below the knee. It was, as I said, a pure below the knee and below the ankle case with calcified arteries and with some issues to be treated. This is the below the knee segment. You can see the anterior tibial occluded at the medium part of the leg, peroneal very thin, posterior tibial with the stenosis in the TP trunk, and patent posterior tibial. So the patient was with this type of foot lesions. As we can see again, very low flow and multiple stenosis in the distal posterior tibia and a couple of occlusions, subocclusions in the lateral plantar. So we take the measurement of the artery with the ultrasound before to cross. This was the diameter, 0.09 millimeters, and two different diameters at the lesion places. We finally cross the lesion endoluminally with an 014 guide wire, engage the lateral plantar, and one of the of the biggest problems with the technology today, talking about below the knee and below the ankle, is to realize if the devices are able to cross. So this is 2.5 shockwave catheter after 6 French long sheath in popliteal artery, no predilatation. The device was pretty well able to arrive almost till the arch. We were able to treat all the subocclusions in the lateral plantar as well in the posterior tibial, multiple dilatations, and the main idea is to be able to repeat at least twice in the same place to be sure to crack pretty well the calcium. We use all the pulses and all the cycles that we have in the balloon to be able to treat as much as possible and to prepare as better as possible this distal posterior tibial and this lateral plantar. And after this, we use a DCB. As always, we post-dilate with a standard balloon, and we use a DCB. In that case, paclitaxel DCB was used to treat lateral plantar and posterior tibial artery. I'm gonna show the result. This was the check after shockwave dilatation. Sorry, we use a 3 millimeters shockwave balloon. So we arrived to 3 millimeters with shockwave and a bit more with a semi-compliant balloon, and this was the result after the treatment with direct blood flow for the foot, very nice posterior tibial and lateral plantar. So the follow-up of this patient at 1 month, there was a small recoiling, but still having a patent artery. You can clearly see by ultrasound the calcifications in the arterial wall. So we met the endpoint of the trial in this case, that was the lumen gain to maintain the lumen gain. A completely different patient with another option. I'm going to try to be fast. It's an 80-year-old male, diabetes, dyslipidemia, hypertension, chronic kidney disease, bilateral peripheral arterial disease, was treated already 6 days before, but was back for acute occlusion, CLTI of the right foot, Rutherford 5, again Wi-Fi score 131, with superficial wounds in the dorsum of the foot and in all the toes, and rest pain. This is the case again. This is below the knee, so above the knee was healthy, no vessels below the knee, distal peroneal feeding plantar arteries and distal anterior tibial feeding dorsalis pedis patent. So completely or relatively easy case. We engage anterior tibial, the 4 French catheter never pass, but the guide wire navigate to the dorsalis pedis. So we shift the 4 French catheter for a balloon. The balloon never passed, and when we inflate, the balloon was broken. So we decide suddenly to shift for orbital atherectomy. That is another tool to fight against calcium. Shift for a Viper wire that navigate pretty well till the foot, and we start with a 1.25 solid crown to treat all the anterior tibial as well the dorsalis pedis. Again, when we talk about technologies to treat below the knee and below the ankle, it's important to evaluate how far away we can go with these new devices. And again, this is another excellent example about the options, the possibility to treat the distal vessels with orbital atherectomy. Balloon angioplasty and DCB after OAS. This was a super selective check to check that there was no embolization. And another important situation with orbital atherectomy is that with one device we can treat more than one artery. In fact, I decided to engage the peroneal artery, the lateral plantar. As I described before, this anatomical variation was present, and using the same orbital atherectomy device, I did the peroneal and arrived till the lateral plantar without problems. Even in this anatomical variation, very complex from the anatomy, was easily to cross, balloon angioplasty and DCB, and this was the final result with fast flow in peroneal and lateral plantar, but still patent anterior tibial and dorsalis pedis. So in conclusions, rudimental tools like Pierce technique, inner Pierce, etc. still support us during the revascularization and treatment of calcified lesions. The technology for sure improved the success rate and improved the long-term results, for example, with IVL or atherectomy, but remember that those are still a vessel prep devices. So BTK, BTA calcified lesions are very bad responder to any type of treatment, POBA, DCB, DES, etc. It's for sure a big need to prepare the vessel in the proper way to obtain a good or acceptable result. Thank you so much, and sorry to be long.